I'm Michael Girardi from the Department of Dermatology, and now I'm going to be speaking to you on an introduction to therapies for cutaneous T-cell lymphoma from the Yale School of Medicine. I'm going to focus on skin-directed therapies. As a dermatologist, we'll see more early diseased patients, and most of the treatments will be directed at the skin. But I'm also going to go into a treatment that for a center that I run here at Yale called photopheresis, that is really geared more towards patients with blood involvement with their cutaneous lymphoma. Our oncologists, Dr. Sethi and Dr. Foss, are going to talk about much more advanced forms across all of these potential areas of involvement: the skin, the blood, and lymph nodes, and treatments that are available, from antibody infusions to single agents, to clinical trials and stem cell transplantation. So when we talk about skin-directed therapies, we talk about treatments that are directed against the skin where the cutaneous T-cell lymphoma is often involved. The three most common forms, and there are other forms I'm going to talk about today. One is phototherapy, where we use ultraviolet wavelengths of light directed against the skin. Another is topical nitrogen mustard, a long, tried and true treatment, which is basically a topical chemotherapy that does not get inside the body. It only stays on the skin. And then skin electron beam radiation, where a specialized form of radiation that also does not go inside the body, is limited to a thickness within the skin to kill the CTCL cells through the skin. So first, phototherapy. There are two major forms of phototherapy that we use. One is called narrowband ultraviolet B light, and the other is called PUVA for short, which stands for psoralen, which begins with a P, and ultraviolet A light. Narrowband UVB has the advantage of not needing any kind of pills or otherwise. The big side effects are driving to a center, getting undressed, and getting in a box. And it's really important that patients expose the areas of involvement. So this often requires removal of all undergarments and ensuring that the sun-protected areas are exposed to the ultraviolet light. PUVA is a more aggressive form of phototherapy that involves taking the psoralen pill first, waiting about an hour to an hour and a half before exposure to a different wavelength of ultraviolet light, UVA. Both of these are usually started about twice a week, but after a patient achieves clearance, they can be tapered to once a week, once every 2 weeks, or even further out. Some of my patients are on once a month with summers off, and that's quite a goal to get for a very low level maintenance therapy. Here's a patient I treated with a hypopigmented form of mycosis fungoides, and clearance we see of the lesions with narrowband ultraviolet B phototherapy. We also see darkening of the normal skin, but this uniformity is certainly a welcome change. Another form of skin-directed therapies include topical prescriptions, ointments, creams, gels. Ointments being greasy, Vaseline-like based applications, creams being more of a white cream that doesn't have as much of a sealing to it, and gels being more drying on contact. Which choice of vehicle of those is used can depend on which type of skin, so it's selected carefully between the doctor and the patient. We talk about topical corticosteroids. Hydrocortisone would be an example of a low-level one, triamcinolone, an example of a mid-level one, and clobetasol, an example of an ultra-potent one. There are so many others, and they will be somewhere along the spectrum of severity of activity. Now, these are not anabolic steroids. They're not going to build muscle. They're not going to do anything along steroids in that way. These are corticosteroids. They're anti-inflammatory. The biggest concerns with these are applying too much in one area over a very long period of time, especially with the very strong forms that might thin the skin. The biggest mistake I see with corticosteroids is not enough application, particularly early on, to help control the disease. A more specific medication that we use for cutaneous T-cell lymphoma that's applied directly to the skin is mechlorethamine gel. This is topical nitrogen mustard under a brand name Valclor. Now, this will be in a gel form, so it'll dry on the skin. It will come with a lot of warnings because you're not to get this inside the body. So that, of course, is something all patients may seemingly look out for, but it needs to be kept in a safe place. Unfortunately, it also needs to be refrigerated. So sealing it up, keeping it in a high shelf, and making sure that no one gets access to it and might mistake it for anything else. Topical mechlorethamine gel works over a long period of time, meaning it won't resolve lesions very quickly. It'll take several months before lesions are resolved. It will not have the side effects of corticosteroids, meaning it won't thin the skin if used repeatedly in one spot. But it is often used with corticosteroids because it can be inflammatory. It can be irritating for some patients. So combinations between these two is more the rule than the exception. Here's a patient with a pigmented purpuric mycosis fungoides, and then treatment with topical mechlorethamine with resolution. Now, when we see resolution, we see the red spots go away. We often see the skin will get a hyperpigmentation as it resolves. This is a good sign. We say we want to see patients go from red to brown for their lesions, and then the brown will take some time to fade itself. Another skin-directed therapy is provided by the Department of Therapeutic Radiology here. Dr. Lynn Wilson has been doing it for many decades at Yale. Electron beam therapy can be a total skin form where you will do it daily for weeks, or it might be a spot form where it's just focused on a particular area of the skin. Your first visit, if you went for total skin, would be a mapping of your skin and your body before the treatment is delivered. Now, in addition to electron beam therapy, there are other different types of radiation that are used depending on what's on the skin. For example, tumors might demand a deeper penetrating form of the radiation. For total skin electron beam, a patient would come in, would have a full discussion, would have a mapping of their skin and their lesions before and after, and then a regimen with dosing and timing would be offered to the patient. It's very individualized patient to patient. Here's one of my patients where we did, in conjunction with Dr. Wilson and therapeutic radiology, a spot electron beam treatment of an area of fairly thick involvement over the abdomen with cutaneous T-cell lymphoma, and we can see that complete resolution of the lesion. Here's a patient who had very aggressive folliculotropic mycosis fungoides all over the scalp and face and other areas of the body. After a combination of total skin electron beam radiation and photopheresis for some blood involvement, the patient had a complete resolution of all of the lesions in the skin and in the blood. This is a newer technology that is being utilized and developed in cooperation with multiple centers across the country, but including at Yale. And this Reflexion will both detect internal and skin lesions of CTCL and at the same time treat those lesions. This is a very exciting newer technology. I'm going to show you a video, and the cooperative is between Yale, Stanford, City of Hope Cancer Center, UT Southwestern in Texas, and the University of Pittsburgh. So normally you might think of a PET CT scan that would find lesions in the body of lymphoma, including within the skin. And this will map the patient for that involvement and then deliver treatment just to those areas. So very selective treatment to the CTCL on the skin and within the body at once. So both a diagnosis as well as a treatment. Here is a patient of mine who had follicular tropic mycosis fungoides. We see two different forms of that. We see these follicular or hair follicles with spines in them, so driven by the CTCL cells to make these clogs. And then we see another one that looks more like clogged pores. And this is on the same patient, just different areas of the body. And this patient treated with topical meclorethamine, in this case, combined with oral bexarotene. So now we have a skin-directed therapy from the outside and a treatment from the inside. Oral bexarotene is a retinoid, goes under the brand name Targretin, but is also available in generic forms. And this can treat follicular tropic, particularly in combination, very effectively, as we see in this patient. So I've told you a lot about skin-directed therapies, and I also want to bring into your understanding of what photopheresis is and what we do for patients with blood involvement. There are other treatments for patients with blood involvement that you're going to hear from a little bit later from Dr. Sethi and Dr. Foss. Photopheresis is refers to this device right here. It's a computerized machine that works on a patient's blood. So it's connected to the patient through an IV or sometimes through a port. And the patient just sits in a recumbent, relaxed recliner, watches TV, reads, or otherwise. And while the treatment is undergoes with the presence of a nurse who watches over and ensures that the machine is doing what it's supposed to do. And what that is that each cycle, it takes an aliquot of blood from the patient, separates out the red cells from the white blood cells, and just treats the white blood cells. Because within the white blood cells are the abnormal cutaneous T-cell lymphoma cells in the lymphocyte compartment. Those are treated with what we heard about before when we talked about PUVA. It's treated with Sorolin in the presence of ultraviolet A light, which is a very effective combination killer of cancerous T cells. This is combined back together and reinfused into the patient. I will tell you that it's a focus of research here at Yale, headed by Dr. Richard Edelson, to understand more fully all of the immunologic effects of photopheresis, including stimulating an anti-cancer response within the patient. So again, photopheresis, one of the treatments we use here at Yale that I'm the medical director for patients with blood involvement, but not the only one. Here's an example of a patient who had extensive mycosis fungoides with almost erythroderma, full body erythema, treated just with photopheresis with that resolution of the lesions. And here we see the level of blood involvement after initiation of photopheresis, even after 4 treatments of photopheresis, knocking it down to normal levels within the body. Here's a patient with a mixture of mycosis fungoides involving the palms, the soles, and then having this purpuric papules around the ankles extending up to the shins. This patient was treated with, again, combination regimen of photopheresis for blood involvement, bexarotene, this oral retinoid, and spot electron beam therapy just to the hands, which were very painful and needed some expedited response. Here you can see the befores, and here you can see the afters of this patient. So combination therapies, including skin-directed therapies, including blood-directed therapies, including radiation, can often become the norm in treatment of patients with complex CTCL. And therefore, this is why, again, it's so important to have such a center that specializes in this disease. And that is my segue, of course, for Dr. Francine Foss and Dr. Tarshin Sethi, who are going to talk to you about some of these more advanced treatments from the oncologic perspective for patients, including stem cell transplantation and clinical trials, as well as our entire team here at Yale, including Dr. Wilson in therapeutic radiology and Drs. Huntington, Seropian, and Asufi here at the Yale Cancer Center in Smilow, ensuring that patients with all forms of cutaneous lymphoma and all forms of lymphoma can be addressed in a very caring way.